So, building up on the previous class on PresbyLASIK, today we'll have a small debate on PresbyLASIK versus lens-based procedures. Some interesting thing about eagle vision. So, we always aim for eagle vision in our patients, but that is not really practically possible because the eagle has two foveas. It has a central and a temporal fovea. Also, the amount of cones in a eagle's macula or the fovea is 1 million cones per mm versus only 2 lakh in our eyes. Secondly, the sensitivity of the cones in an eagle's eye are much more than our normal human vision. They can also see UV radiation. Their field of vision is almost around 340 degrees. The right eye can see a single image in the right eye, and the left eye can see a separate image in the left eye and also still function without having diplopia. And fourth thing, they have a nictitating membrane which is going to cover their eyes and lubricate their eyes and create a clear optical surface. So just a side note on eagle eye vision. So coming to the problems of multifocal IOLs, these are very well known. Multifocal IOLs, of course, is an intraocular procedure with their own due risks of posterior capsular opacification, rent during the surgery, endophthalmitis, steroid macular edema, retinal detachment, and so on. The multifocal IOLs also have a risk of long-term IOL dislocations, which is similar to what we see in any other IOL-based procedure. Most importantly, multifocal IOLs patients do have glare and halos, and patients do have starburst, especially on night driving. Multifocal IOL patients do have a loss of contrast sensitivity and especially prone to having refractive surprises if the biometry is not very accurate. And if eventually we are going to end up doing a laser based procedure for that refractive surprise, why should we not start with the laser based procedure in the first place? So I'm going to tell you how laser based corneal procedures solve all of these problems. So, what is the target population we are considering for this debate? In this debate, we are basically considering the people who have a clear lens, who do not have a cataract. So, if for a person who has a healthy lens, their transmission of light is 100%. In a cataractous lens, the transmission of light is low, and if we put a multifocal IOL, then still the patient with 85% of light transmission with the multifocal IOL can still be happy. However, a person with a healthy lens who has 100% light transmission, if you get them down to 85% light transmission, they might not be necessarily happy. So another point which has been said about the presbyopic laser correction is that the near ad is not sufficient enough. So in the IOL based platforms, initially they were giving +4 ad, plus 3.25 ad, and plus 2.75 ad. So they have noticed with clinical studies that the near vision acuity is actually better with lower ads. Okay, so the patient satisfaction in this study, as we can see, is significantly better with a lower ad than a higher ad. So we may need not necessarily give higher ad to the patient to achieve 100% reading ability. Secondly, despite reducing the ad, the presence of glare and halo in multifocal IOLs is significant, coming up to close to 40% in all of the cases. The contrast sensitivity also in multifocal IOLs is significantly lesser than the monofocal IOLs. So how do PresbyLASIK patients get a benefit over multifocal IOLs? So there is no risk of intraocular procedure. They have very low incidence of glare and halo. They have very good functional vision. We have a good safety and track record of MTOLASIK, and enhancement and reversal. Both the procedures are extremely easy at the click of a single button. So for the case of this discussion, I am not going to include Presby Max and Supracore, which intend to create multifocality onto the cornea, because multifocality by itself, be it on the cornea or on the lens, do come with their own set of problems. Hence, Supracore and Presby Max are falling behind nowadays, and people have shifted to something which is called as laser blended vision, which is also known as Presbeyond, which can be done on the Zeiss platform. So I'm going to talk about the best available corneal laser procedure nowadays, which is PresBeyond, and how it is better than multifocal IOLs. So in a study conducted for PresBeyond, we can see that in PresBeyond in the non-dominant eye, we aim for a minus 1.5 diopters refraction. At this minus 1.5 diopters refraction, we expect the vision to be somewhere around 20 by 100. But in the study, they have found that even the near dominant eye, the non-dominant eye which is corrected for near, it still has a good vision of 20 by 60 in almost 80% of the patient. Similarly, the distance dominant eye achieves 20/20 or better in at least 92% of the eyes. And if we add to the dominant eye cues from the non-dominant eye, almost 96% of the patients binocularly read 20 by 20. So the rate of achieving emetropia or binocular 6/6 vision is very, very high in PresBeyond. What about the stereo acuity? Two separate studies have been conducted. The study on the left is by Reinstein et al. And the study on the right is by the publication from Russo et al. In both of these studies, they have shown that almost 97 to 98% of the patients have achieved less than 200 second arc of stereopsis. Similarly, in hyperopia and myopia, both the groups in a study conducted by Russo et al., we see that almost all a significant chunk of the population do achieve around 140 to 100 second arc of stereo acuity. To put this in perspective, threading a needle takes around 300 to 400 second arc of stereo acuity. So this stereo acuity certainly can be considered acceptable, although you can find various studies labeling normal stereo acuity at somewhere around 40 to 60 seconds of arc, but we do not really do any manual task or motor skill which requires that high level of stereo acuity unless somebody is a surgeon. What about the distance and near visual acuity in all kinds of refractive errors? So in the studies conducted by Reinstein et al. In different refractive errors for myopia, hyperopia, and emetropia, the results of the distance and near visual acuity are fantastic, wherein almost 98 and 99% of the patients reach 20/20 and J2. In hyperopia, almost 77% patients reach 20/20 and J2, and in emetropes, almost 95% of the patients. So the visual acuity is a very good outcome in both myopia, hypermetropia, and emetropia. What about the subjective patient experience? So, in this study conducted by Dr. Sri Ganesh et al. About PresBeyond, we can see that the distance, intermediate, and near vision in almost all of them is excellent, and they have reported almost 100% of spectacle freedom. Similarly, if we consider dysphotopsias, almost 95 to 92% of the patients have no dysphotopsia, and rest of the patients still have very mild grade 1 dysphotopsia. So they are achieving almost 100% spectacle independence, and they are having almost minimal dysphotopsia. Their stereo acuity is also extremely good. In another separate study conducted by Russo et al., spectacle independence is almost close to 100%, and the rates of dysphotopsia are almost negligible. So the visual acuity and the subjective symptoms, stereo acuity, all of them are excellent with PresBeyond. Hence, the problem with any correction is the multifocality rather than the modality of the treatment. So multifocality is going to cause you to have a problem in night vision, reduced contrast sensitivity, intolerance, and if we do a multifocal intraocular lens, the retreatment options are very limited. On the extreme, monovision also has a lot of problems in which the patient is going to have really poor intermediate vision and has low tolerance. So nowadays what we are doing is using micro monovision to create a spherical aberration and give enhanced depth of focus, either with a corneal based procedure or with lens based procedure. So the tolerance for them is extremely good, especially for press beyond, wherein we know that retreatment or enhancement or reversal is easily possible. So that was my presentation, sir.
Nice. So I think we'll go ahead with Shruti's presentation and then we'll have a discussion.
Yes, sir.
Pranav, can you please disable screen sharing for me?
Mm, just a minute. I'm seeing how to do
I think you
this.
have disabled.
Can you try now?
Yeah, wait.
Are you able to share?
Yes, just a second. Is it visible?
Yes.
Okay. So I'll go ahead with the topic, but before that, I'll have to give a brief information about lens-based procedures in presbyopia. So, presbyopia is an age-related vision disorder characterized by the progressive inability to focus on near objects, and it is hypothesized to be caused either by the weakening of the ciliary muscles or loss of lens elasticity. So the dependence on the spectacle is one of the main cause of loss of quality of life in people around 40 to 45 years of age. So there are apart from spectacles, surgical options which are available. Uh, exactly. Surgical options which are available, they can be cornea based procedures like Pranav talked about them. I'll be talking about refractive lens exchange lens based procedures, which can be monofocal IOLs giving monovision, multifocal IOLs, accommodative IOLs, and light adjustable lenses. So refractive lens exchange is a in this natural crystalline lens is replaced with the synthetic intraocular lens. We can achieve this by implanting monofocal lens and creating monovision, in which the dominant eye we will correct for distance and non-dominant eye we will correct for near. But there are problems with the stereopsis in this, so I will not be talking about this. So I'll go ahead with the premium IOLs. This can be multifocal IOLs or accommodative IOLs. Multifocal IOLs can be refractive and diffractive, and accommodative can be dual optics and single optics. So the multifocal IOL, which are refractive multifocal IOLs, are of two types. Sectorial, in which these are bifocal. The central part will cover the near vision and the periphery will be there for the distant vision segment. Whereas annulus type of IOLs, there are multiple zones of near and distance correction. So these both procedures are pupil dependent procedures, as when you go in the sunlight, since the near triad, in the near triad, the pupil will be in the smaller size. So the central part is used for the near vision. But the problem with these lenses is when you go in the sunlight, and when you want to see at the distant object, since the pupil will be of smaller size, your distant vision will get compromised. So there was advancement, and diffractive multifocal IOLs were introduced. They have continuous concentric microscopic steps which form the diffractive zone across the lens surface. The width and the height of the step will affect the effective power of the lens. It produces the two diffractive orders incoming when the light is incoming in the same phase. It will diffract the light, and two focal points for distant and near of equal intensity will be produced. The step of the height determines the phase delay, and the simultaneous focal lengths for distance and near occur at the same time. It is very, since these steps are concentrically arranged, and there will be very little dependence on the pupil size, and even the decentration while implanting the IOL will have minimal effect. So as we all know, and Pranav also talked about it, that with multifocal IOLs there are problems of glare and halos. So these problems are corrected with trifocals. So halos are basically formed when the near image is blurred with sharply focused distant image, or vice versa. So for that, in the trifocal lens, the height and spacing of the diffractive rings are reduced, which reduces the scatter from periphery and decreases the glare. The rings are smooth and the rounded edges, which also reduces the glare. The partial optics diffractive lenses, in these diffractive rings are only in the central 3 to 3.6 mm of the zone, and because of that, in the night time also, people who want to drive, they will achieve better vision without glare and halos. There are also apodized lens. In this, it consists of the concentric rings which show a decrease in the height from a taller center to the shorter outer step. And the advantage of this, there will be the gradual change in the height, step height, and that decreases a sudden shift in the optical boundaries, which will reduce the distraction of light, and that will produce the less glare and halos. So these are the lenses so the Restore is a diffractive kind of lens which we used to use before, and the refractive kind of lens is the Resume by AMO. So these are the multiple premium lenses that we use nowadays. Uh, uh, Trifocal lenses like Panoptics by Alcon, and Synergy by Technis or Johnson and Johnson. And by Zeiss, there is at least a trifocal. Um, So, extended depth of focus lenses. These are in this, the proprietary diffractive optic design is such that it extends and elongates the focal point, which will enhance the depth and the length of the focus. So it uses achromatic technology, which corrects the chromatic aberrations that are there with the multifocal IOLs. So these are better, these give good distant vision and good intermediate vision. Around minus 1.25 diopters of extended range will be achieved with these lenses. These lenses are of two types. One is EDOF, and other one is enhanced monofocal lenses. So in the enhanced monofocal lenses, the beam shaping is extended, and these lens in these lenses, the geometry of the lenses is such that the central optic they cause the change in the power from center to periphery in the either increasing in the central power of the lens or elongation of the focus by the wavefront modulation effect. So the example of enhanced monofocal lens is Ray-1 EMB. So these are the different kind of premium IOLs which are available, and they offer these ad. So now, like Pranav told, so with Technis multifocal, the acceptance is more with the lower ads. So nowadays, the higher ads are not used. Then there are accommodative IOLs which respond to ciliary body contractions and include and thus inducing accommodation. So the haptic flex, there is anterior movement of the optic by 0.5 diopter to 1.5 diopter accommodative power is induced. These are of two types: single optic types and dual optic types. In the single optic type, the lenses which were used was Boston crystal lens by Bosch and Lomb. In the dual optics type, the high plus, there will be two optics, the high plus anterior lens and the minus posterior lens. So in the non-accommodative phase, the optics are in the proximity, whereas in the accommodative phase, the zonules will relax, and the two lenses, the two optics will separate. Then there are light adjustable lenses. These are not used in India. So these are silicon matrix. They have silicon matrix with photosensitive molecules embedded in them, which permit the post-operative titration of the IOL power after the eye has healed. It facilitates customization and optimization of lens to achieve the desired prescription. So the low intensity UV light is used to for the correction of the residual error. The UV light will cause the polymerization of the photosensitive molecule, and which will create the concentrated gradient across the lens. The migration of the photosensitive molecule will happen over 12 hours, and this irradiated region will swell up, and it thus the power of the irradiated zone will increase. These are also used for astigmatisms. So this is just the diagram showing how light adjusted lenses are used. So I'll come to the topic where I'll talk about, so why should we opt for refractive lens exchange? So they improve the quality of life. As we know, it offers significant improvement in the quality of life for individuals suffering from presbyopia. It restores the clear vision at various distances. Patient can enjoy activities which are outdoors. He also can enjoy reading, and for intermediate, he can enjoy digital devices. And with trifocal lenses, there is a reduced while driving also, there is reduced glare and halos and no dependence on the glasses. So also it provide the refractive lens exchange, it will provide the long-term solution. So before I talk about refractive lenses versus PresbyLASIK, I would like to tell that even patients of presbyopia who opt for reading glasses, for them the reading glasses is not long-term solution. The glasses often get lost and misplaced, and they have to change the addition after every 2.5 to 5 years. So these refractive lens exchange will provide the permanent solution for them. About the calculation of the power for the refractive lens exchange, nowadays with IOL Master and LensStar, the accuracy of biometry has increased. There are various studies which show the safety and efficacy of IOL-based correction. The procedure has high success rate with most patients experiencing improved vision and satisfaction post-operatively. So there is a study by Stephen et al. To compare refractive visual outcome, patient satisfaction and complication rates among the different age categories of the patient who underwent refractive lens exchange. So there were 4 groups of different age range, and it was found that refractive lens exchange can be safely performed in younger patients as well as older patients of the presbyopia. So there are people who are talking about that refractive the presby-LASIK will be better for the younger patients, and refractive lens exchange can be better for the presbyopics who fall in the older group. So this study basically talks about proves that it can be safely performed in younger as well as older population. So while also with the technological advancement, there is a low incidence of glare and halos, and uh, as uh, as as we can see, the light transmission through the multifocal IOLs, there is the light will diffract and there will be the spread of light for far as well as the near vision. The light loss for multifocal IOLs is very less, around 12 for the accuracy of panoptics. So it will give good contrast sensitivity while maintaining good far as well as near vision. So this is the study by the Moses et al., which talks about presbyopic patient who underwent bilateral refractive lens exchange with implantation of at least a trifocal IOL. They experienced improved near, intermediate, distant vision 6 months after the surgery as compared to their pre-op vision, and the total internal aberrations were also reduced significantly. According to the FDA clinical trial of Technis multifocal IOL, which took place in 2016, this clinical trial evaluated the safety and efficacy of the Technis multifocal intraocular lens in patients undergoing refractive lens exchange for presbyopic correction. The results demonstrated significant improvement in near, intermediate, and distant vision, with high proportion of patients achieving spectacle independence for various daily tasks. The study also reported low rates of adverse events and high levels of patient satisfaction, supporting the use of multifocal IOLs for refractive lens exchange in patients with presbyopia. So why should we prefer refractive lens exchange over presbyopic LASIK? So as I told, refractive lens exchange will provide permanent solution. As we know, even if you do presbyopic LASIK in young presbyopes, as they will age, there will be lenticular changes, and at some point in their life, everybody will have to undergo cataract surgery. So with refractive lens exchange, there will be one solution for 2 problems. Whereas with presby-LASIK, the patient will have to undergo 2 different procedures. So it will not give permanent solution. With as we know, the lens-based correction provide the stable and permanent solution to vision problems. Once they are implanted, intraocular lenses will be there in their position and they'll maintain their corrective effect over the time. Whereas with presbyopic LASIK, we reshape the cornea, which can lead to later regression and changes in the vision over the time, necessitating either retreatment. There won't be since we are implanting the lens intraocularly as compared to as opposed presby LASIK, we don't have there won't be any epithelial remodeling, and epithelial remodeling related complications won't be there in the refractive lens exchange. Refractive lens exchange is suitable even for the higher refractive errors. So even higher degrees of myopia, hyperopia, which may not be treated with LASIK surgery due to
Sorry to
corneal
interrupt.
thickness.
Sorry to interrupt. This meeting will get over under 1 minute, so I am forwarding another link for the
Okay,
second thing. So
okay,
till then you can continue, but I am also forwarding the second.
okay. Um, yeah. So um, as we know, the refractive lens exchange. So refractive lens exchange can cover even higher degrees of refractive errors, which will be a limitation for LASIK due to corneal thickness limitation. Uh, Refractive lens exchange will be suitable for even for the patients with thin corneas and irregular corneas, and there won't be any risk of post-LASIK ectasia. Also, there are with refractive lens exchange, the incidence of the dry eye won't be there as compared to LASIK-based procedures. Also, refractive lens exchange is a cost-effective procedure because first thing, we won't need two procedures as in PresbyLASIK, patient will have to undergo two procedures at some point in his life, whereas with refractive lens exchange, it is a permanent solution. Also, for doctors, also it is cost-effective because no additional skills or technology will be required for the refractive lens exchange. And any cataract surgeon can do refractive lens exchange, whereas for LASIK surgeries, they will have to undergo training, and uh, the machinery required will also be different. So why should we not go for PresbyLASIK? So basically, there are many doctors who feel that it is a presbyopia is a lens condition and it should be solved at the same level. It shouldn't be solved at the corneal level. Also, with the PresbyLASIK, there will be marked induction of higher order aberrations to create multifocality. With PresbyMax and SupraCore, they compromise the distant vision, so they give quantity, and the quantity is compromised at the cost of quality. The press beyond procedure, we say that Presby is reversible procedure, but press beyond procedure is not reversible. There are risks of decentered ablations. So PresbyLASIK, maybe it can be a viable option for young presbyopes, but it will provide only temporary solution with mean of 5 to 10 years. With double curve hyperopic LASIK, there will be significant regression by 3 to 5 years. For PresbyLASIK, additional cost of machinery and licensing will be required. The specific knowledge of presbyopic profile will be required for the surgeon. There will be PresbyLASIK people will need cataract resurgery, and there will be difficulty in the IOL power calculations for such patients when they develop cataract. And with PresbyLASIK, it treats till plus 2.5 diopters of near ad. So in some patients, after 5 to 10 years, they will need glasses for near vision. So there are no direct study which will actually compare presbyopic LASIK versus lens-based procedures. So I found this one paper which for the comparison of different presbyopic treatments, refractive lens exchange with multifocal intraocular lens implantation versus LASIK monovision. So the conclusion of this study is refractive lens exchange. It enables good near and distant vision and high spectacle independence. The visual disturbances might be serious disadvantage, But LASIK monovision with residual myopia of -0.5 to -1.25 diopter gives good distant and intermediate vision to person between 40 to 50 years. Near vision can be satisfying for some period, but after 50, they will need reading glasses. So the choice of refractive procedure must be personalized, and preoperative counseling is the key to success. So,
Uh, Good job,
so
both of you.
basically, all
Yeah.
so basically, even whether it is corneal based procedure or lens based procedure, most of the studies actually they state the same thing, that uh, creating multifocality, whether it is lens based or cornea based, will have problems of glare and halos, and monovision will compromise the distant vision at some extent, whether it is lens based or cornea based. So the creating spherical aberration and using EDOF lens, or at cornea based producing micro monovision is the solution, whether it is cornea based procedure or lens based procedure. So the chances of like patient satisfaction is more with the micro monovision at cornea level and EDOF lenses for lens based procedures. Thank you, sir.
Great, good. So I think we had a good debate, and I'll request Dr. Amrita and Dr. Ruchika to put up any questions.
Sir, I think you should do the honors because you have maximum experience with both the procedures. So,
I was just thinking that if we have a slightly different perspective, so it'll be nice because there must have been some questions which cropped up in your minds, like especially about PresbyLASIK and what are its limitations compared to RLE with multifocal IOL. So I just thought if what are the points of discussion. For example, I thought that there was one question in my mind that for example, PresbyLASIK, which is the ideal age group? Is it in the 40s? Is it the 40 to 45? Is it the 45 to 50? Or is it the 50 to 55? Or is it over? Like, how do these four group of people kind of, respond to PresbyLASIK? So if we do it in the 40s, early 40s, late 40s, early 50s, or the late 50s, how will the result vary? That was one question. And second question for Pranav was that somebody who has undergone PresbyLASIK, following PresbyLASIK, what are his options for IL choices when he does go on to develop cataract? And at that time, will using a monofocal lens allow him to still use the multifocality of the cornea to be able to read? These are the two questions I wanted to ask
Yes,
you.
sir. So I will go point by point, sir. So we asked about what age group is going to be benefited the most. So it is not related to the age per se, but the functional age of the patient and what is the near ad and the occupational need of that patient. Certainly, Indian population, if you see, the Indian population is said to get cataracts at an earlier age as compared to the European population. In our experience, also, if we have a lot of non-Indians, we see that they tend to have lesser cataracts at older years of age. So, in Indians who are going to get cataracts at slightly earlier age, even though when their ad is going to be somewhere around 2.5 and not reach an ad of plus 3 diopters, then the add of plus 2.5 diopters, which PresbyLASIK, which Presbeyond is giving, is going to be sufficient. We are not going to take that patient up to 65 or 70 because the incidence or the lenticular changes in that patient are going to increase. Certainly, if we are going to do in the second question, if we are going to do a monofocal lens in that patient, because we have already created negative spherical aberration into the cornea, We are not going to use any negative spherical aberration lens or a positive spherical aberration lens. We are going to use a normal zero spherical aberration aspheric lens in that patient. And after that also the corneal effect is still going to be there, because we are in press beyond, essentially we are not creating multifocality, we are creating a depth of focus. So that is the question. Third thing, one thing I might beg to differ from Dr. Shruti, that she has mentioned that refractive lens exchange is a permanent solution. However, if you are going to do a refractive lens exchange in a 40-year-old, by the age of 60, they are going to develop some against the rule astigmatism. And there are studies which are going to show that against the rule astigmatism, as you age, you can have significant against the rule astigmatism. So if the patient is going to develop -1 or +1 diopters of against the rule astigmatism, it is not a permanent solution. Thirdly, in the study which is shown by Dr. Shruti, where she has shown the RLE outcomes, if you read into the results of that paper, briefly what I read, the binocular visual acuity in percentage of people which she has shown is somewhere around 80 to 90% as compared to group A, B, C, D she had shown that study. Whereas in PresbyLASIK, the binocularity is extremely good. I mean, the distance, intermediate, and near vision. And thirdly, she has mentioned that press beyond is not reversible, wherein press beyond is actually reversible. So these are my thoughts.
Yeah, that's these are good points. And the only thing is that also biometry challenges after Presby LASIK. So what will be, because we do have now various calculators and formulas for all the other situations, like for hyperopic LASIK, for myopic LASIK, for RK. But do we have, how would we go about choosing the correct ILPAR for a patient who has undergone presbyLASIK to
Sir,
achieve emetropia so that that effect of presbyLASIK works?
sir, for a person who is undergoing Presby LASIK, they are going to do it at a premium center, and obviously they are going to have the reports of that pre-operative K values and pre-operative values. So on the basis of that, we can get a fairly accurate uh,
No, no, but which formula
refractive
will you
outcome.
use? Like we have almost all the devices and everything. And suppose we were doing it for a patient and then that patient comes back after 5 years. How will you go about it?
Formula, I am not sure, sir. But anyway, sir, formula you are
That's
going to, for one eye the formula is going to be fairly simple. Normal post myopic LASIK, sorry, post LASIK formula we are going to use for the dominant eye, which is distance corrected. Only for the non-dominant eye, which is near corrected, we are going to have to struggle to find a formula.
But that will cause lot of problems now if in one eye patient is the IOL power if it is not correct.
Even if the IOL power is not correct and the corneal plane, they can be corrected at a later date.
So I think we need to study a little more about possibility of like biometry challenges in eyes which have undergone presbyLASIK, and which formulas we can use, because even I'm not aware that which formulas might be used, but I'm sure this must be there in literature, that which ILPAR calculation method will work best for presbyLASIK, post presbyLASIK eyes, because this will become important. And especially because this will also limit the choices of the patient for they will not be suitable candidates anymore for any kind of multifocal lens, because already the cornea has been made multifocal as well, right? So these are just thoughts which
Also,
came in
I
my
have a
mind.
question here. Sorry, I have a question here, sir. What I wanted to ask them was that both these techniques that we are talking about are mainly being discussed only for normal patients. And quite the diabetic capital being in India these days, then what will happen once the patient starts developing in the retinal changes? So, is there a priority? Which procedure do we want to go ahead with for a longer term? Because initially, patient might not be presenting with any retinal diabetic retinopathy changes, but in due course of time, if patient does, then it does the decision still get biased based on that decision, or still we are going ahead with any one of those based on patient preferences and age related things that we were discussing yet?
Ma'am, currently, though, if we are coming across any diabetic who currently does not have any diabetic retinopathy changes, then there is no literature to suggest that it is any contraindication for any multifocality.
So yeah, even for lens-based or
In the multiple.
cornea-based,
Hmm.
even for lens-based or cornea-based procedures where we are inducing multifocality, for both
Hmm.
exclusion criteria is no corneal pathology or no any retinal pathology.
Yes,
So
so
there are no
initially,
evidences.
because initially I remember that in the multifocal lenses, now with the eye hands and the other trifocals, the situation has become a little more better. But with the initial multifocals, diabetic retinopathy and retinal changes per se are a very big highlight to exclude, to be considered for a multifocal lenses, as you just mentioned. Now, these days, we are not like obviously we have that threshold, but I think it's kind of reduced based on patient preferences also. And maybe if we have the previous records and the patient's retina looks fairly clear at the time of doing it.
Ma'am,
But I
applying
think
the
there's still
same,
some places.
if we apply the same
Hmm.
logic to all multifocal patients, then we may never insert any multifocal in any patient because
No,
we
I
don't know the
understand.
risk of
Hmm.
getting ARMD in any eye.
Hmm.
So that is always going to be there. So currently, if the patient does not have any retina changes, then multifocality can be induced either on the cornea or on the lens. And I feel maybe corneal multifocality would be suitable rather than a lens multifocality.
And also, I think one more thing is if the patient ends up presenting with the mature cataract, then again the calculation becomes a little more uh, like less accurate for the multifocal IOLs
Hmm.
because the entry for the exit length and everything ends up getting a
Becomes
manual
biometry,
entry.
yes.
Yes, yes. So I think that is also one of the things to remember because I think I have seen some patients in the OPD in which one eye was put up with the multifocal, and that's how we could go ahead with the other eye, even with mature cataract, because we had the previous reports with us or something similar. But on the other hand, if the patient presents with mature cataract on day one, then again that becomes a question.
But ma'am, we are talking
Yes.
about the refractive lens exchange in which for the presbyopia
Or
in
the
which there
yes.
are no cataracts. Huh?
Hmm.
And also, if I
Nice
may,
point.
we are comparing apples to oranges if we are comparing EDOF lenses or enhanced monofocal lenses with presbyLASIK because in monofocal plus or EDOF lenses, their patient is going to need near ad and need glasses for reading fine print. So if we are going to make a fair comparison, we have to make a comparison between multifocals, light adjusted and accommodative IOLs versus corneal procedures like presbyopia.
Mm, nice. So I think another thing which we probably missed talking about was uh, potential complications. You know, you did list them in one thing, but if we had some studies to show what might be the incidence of, for example, retinal detachment following high myopes, cataract surgery, or a refractive
Cataract
lens
surgeries,
exchange,
yes.
that would, kind of give us more insight, like especially if there was a comparative data of a normal eye versus a highly myopic eye or a high hyperopic
Hmm.
eye, if they are more prone to get complications from a refractive lens exchange as compared to a normal eye, number one. And so high refractive errors, hyperopia or myopia, because these are the people who will usually come to you for a refractive lens exchange or a presbyopic lens exchange. And number two, also, I felt that if we had data on complication rates from, I mean, comparing duration based. For example, if somebody has undergone a refractive lens exchange at a much younger age, say in the 40s, so in 20 years, what is the chance of getting a retinal complication? So time-bound
Hmm.
complication rates also might be useful to highlight. So these two things I think we can add to this debate basically because that will help us decide better about whether uh, refractive lens exchange is as safe as cataract surgery in the elderly age group, or it poses more risks to the patient. So because these are healthy eyes which have otherwise no cataract, they are just having a refractive error, and then we are going to do laser correction.
Sir, one more thing about safety of refractive lens exchange, I would like to add, as I was reading about the opinions of different doctors. So nowadays, with advancement of technology, we can also offer the femto cataracts also. So femto based cataract also we can offer, and that will reduce the chances of PCR and other complications, intraoperative complications, and it will increase the safety. So that I
Right.
forgot to mention.
No, that's okay. So I think we've had a
Sir,
good discussion,
sir, I
and
beg to differ in this. Dr. Shruti had made a point that it does not need any additional machinery, additional expertise, or any cost to the doctor. But if you were to opt for a femto machine, that is going to drastically increase the cost. So this
yes,
No,
cannot be
it's
done
so
by everyone then.
no, not everyone. If you have, then yes, to add to safety, you can. Otherwise, any anterior segment surgeon who is operating cataract can go for RLE.
So the additional safety is available only to a small percentage of the population.
So there are no actually studies or there are no studies which will prove that. These are just the opinion of the doctors that I was coming across.
right. So I think we've done a good job, and we've had a good discussion, and both are actually good options, and we still don't have the option of doing PresbyLASIK, so we are limiting ourselves to monovision and micro monovision basically, and EDOF lenses, and then trifocal lenses. So only thing is that in the US now they actually offer clear lens exchange and this thing for presbyopia to even younger than 50 years age group. We probably don't do that. So other than RLE, we are now, RLE might still be an option for very high refractive errors like those -20 myopes that we see. But in PresbyLASIK, where person may be emmetropic for distance, then offering a presbyopia correcting lens might be a more challenge than, doing it for a patient who has a refractive error as well as presbyopia. So a plano presbyope is definitely going to be a much more challenging case for either of the two procedures. So I think,
Yes, sir. Actually, sir, I found one blog about this. So it takes the opinion of the 4 5 surgeons, not from India, but so there are almost 4 to 5 cases. So since whether to go for RLE or cornea-based procedure, it depends on the person, the patient profile. So they have discussed a few cases, and on each case they have taken opinions of different doctors. So that blog is also very interesting. And at the end of that blog, it's the same thing that uh, so the cases in that blog are very very interesting. Basically, some are if presbyopia between 40 to 45. They have decided age group also. There are cases about different occupation also, how that will also affect whether to go for RLE or cornea based procedure.
right, right. Okay.
Also,
So I
another
think that.
question, sorry,
Mm.
one question I have for Pranav. There was this thing when we were noticing we were trying to study for the eye hands lenses initially, what exact ad do we need post-operatively with them? And we had quite noted that the facial structure of some patients also made a lot of difference in this. So does the presby LASIK also will have an impact on that? Because, for the myopic lasers that we do, the myopic LASIKs that we are doing, the patient is focusing the distance overall, and the facial morphology does not play so much of a role in how close the eyes are and when you're trying to read the angulation at which the things have been held. So does presby LASIK also have an impact with that also, or does not really matter too much with it?
I didn't understand the question, ma'am.
So we've kind of found out that the patients who are coming from the hills who have a little more distance between both their canthuses, so when they were trying to read something, the angulation at which they used to hold the book was quite different from the other patients, not just associated professionally, but also because of their facial morphology. So is there something that you've read regarding this, that the presbyLASIK will need an adjustment to it, or no, just a normal presbyopic correction can be treated in a normal way in all the patients?
So in fact, PresbyLASIK in this regard is more advantageous than a refractive lens exchange, because in refractive lens exchange you are going to get a fixed ad for distance intermediate and near. If
Hmm.
a female patient is 4 feet 9 inches and her one arm distance or reading distance is, say, let's say, because her hands are very small, it is say 25
Hmm.
centimeter. Contrast that with
Hmm.
somebody who is a 6'2" person and his hands are very big and he is going to put his reading material far away from his eyes. The lens is
Hmm.
not going
Hmm.
to perform the similar way in both of them. Whereas in
Hmm.
PresbyLASIK, you can actually determine the working distance for that patient and modulate your treatment accordingly.
Hmm.
Also, Pranav, I had a question. You said that PresbyLASIK is reversible, but does the reversibility also depends on the previous distant refractive error that patient had? Like it is, if you have corrected only a small distant vision in that, then only you can go for, I mean, it can be reversed. Is there something like that?
What do you mean by small distant vision?
I mean, the refractive error, if it is only small refractive error,
Hmm.
so the correction that you have done. So last time also, I think I had asked you this.
If
For
there is adequate
the
corneal
ablation
thickness,
you are
yes.
talking is the less ablation you are talking is only for the near, for distant. So that only you are comparing. When you
Hmm.
say minimal ablation required, that is only for the near. But when you are correcting patient who has refractive error for like who are myopes and hyperopes as well, so in them also can you reverse it, or there are some limitations to it?
The limitation being that patient should have adequate corneal thickness. Nevertheless, if the reversal is required, it is still going to need only around 20 to 25 microns of ablation. And since our tolerance for residual stromal bed anyway is 250 microns, and we are not going to treat anyone who is going to come close to 250 microns, on an average, if we are doing even high corrections, we still leave the patient with somewhere around 380 or 280 or 300 microns of residual stromal bed. So that additional 250 micron, 25 microns can be certainly done.
Okay.
So let's call it a day. It's been very interesting and good debate. And what should we keep for our next debate?
Sir, actually, we wanted to request that we need some time for the next 2 weeks to prepare for the AOS submissions.
We should. So, ठीक है. Let us keep our next class on what we are going to present in the AIS. I mean, what we are submitting for AIS.
Yes, sir.
Okay, sir.
Okay. So I think let's do that. We can come up with what all we have prepared and what we are planning to submit, and let's have a discussion on that so that we can submit it in a better way.
Yes, sir.
Okay.
Yes, sir.
ठीक है. Great. चलो ठीक है, and that will help us guide you also how to go about it. Okay.
Yes, sir.
Yes, sir.
चलो जी. Thank you so much. Thank you
Thank you,
and
sir.
good night to
Thank
all
you,
Thank
of
you.
sir.
you.
Good night. Thank you. Bye.
Good night. Bye-bye.